Okay, hi everybody, my name is Toby Lineaweaver and I'm coming to you from Recovering Champions, and we're going to have a brief chat about another topic that we're all interested in that's very near and dear to our work in the substance abuse field, and this is about medication-assisted treatment, or the use of methadone, Suboxone and its derivatives, and naltrexone and Vivitrol to help people maintain their sobriety and recovery. Once again, this talk is meant to be informational, to generate interest and discussion. I'm not going to get technical, nor do we intend to be definitive, but to give some general guidelines and help maybe folks get a little bit past some of their reactions or overreactions to medication-assisted treatment, and maybe some of their misperceptions about it. So the topic is very controversial. Most people, when you think about methadone and Suboxone, tend to have a negative reaction. These are abusable and divertible substances, and by diversion we mean people who get prescribed these, particularly Suboxone, and then rather than taking it, sell it on the streets. And a lot of people in recovery themselves tend to view those that are on MAT as not really being clean and sober. And that can be a problem for the person who's never been able to be clean otherwise, going out into the world and trying to gain acceptance and belonging in the 12-step and other fellowships. So public policy, however, is changing, and for darn good reason. The opioid epidemic is rampant, as we know, and there's many deaths from overdose. And public policy, both here in Massachusetts and across the nation, is really driving the use of MAT as a way to stem the tide of this epidemic and to save lives. And without getting into citing anything in particular now, I think I'll just say that there's abundant research out there, good scientific studies that point to the efficacy of MAT in saving lives from opiate overdose. So the challenge is how to blend all our feelings about it, the knowledge about it, and decide in the end what is best for each client. And that can be a little bit tricky, but there are some ways of looking at it I think you might find helpful. Now, there are the three options. I'll go over them again. There's methadone, which has been around for quite some time, Suboxone and its derivatives. And Suboxone itself is buprenorphine mixed with naloxone, which is something that blocks and protects. And then there's Vivitrol, which is injectable, or naltrexone, which is the oral form, which is just a blocker. The way that we explain what all this means is I use the parking lot analogy. So here I'm going to go to my visual aid here. If you think about this is the synapse in the part of the brain where the opiates have their effect. You have the nerve that releases the neurotransmitters, and then the nerve that receives them. And our body does have its own natural opiates, the endorphins. We've all heard that. They give us well-being. They help dampen pain a little bit when we're in pain. But what heroin and all its opiate and opioid relatives mimic most accurately is the shape and size of the neurotransmitters, and they fit into the parking lot spaces perfectly. And in doing so, create what we call a full agonist or a full opiate response, which would include sedation, pain relief, or analgesia, and then the euphoria. Suboxone, so methadone as MAT does provide the full opiate response. Suboxone is more like people are just parking cockeyed in the parking spot, and in doing so creates a partial agonist, and creates a partial opiate response. And in the case of Suboxone, that would be the sedation or relief from the urges and the cravings, and the anxiety associated with the withdrawal and the ongoing healing from the addiction, and also the analgesia. And Suboxone, therefore, can be very good for people with chronic pain. And then over here would be what the action naltrexone does, which is blocks. These people are blocking the parking spaces so no one can use them, and that is actually an antagonist. So Vivitrol and naltrexone is an antagonist. We find that in deciding which one to use, the full, the partial, or the antagonist, meaning methadone, Suboxone, or the Vivitrol, naltrexone, deciding which is best for a client depends on a lot of things. And one thing that I learned when I was working with a team in Taunton a while ago was they would look at the needs and the recovery environment and the demonstrated ability to maintain good self-care as one indication of which of these that they needed. And they would say that each of these different substances represents a leash of a different length that is used to keep people safe and in treatment, with methadone being the shortest leash because it is dosed daily and therefore is best recommended for people that need the most immediate harm reduction, that need daily eyes on and daily attention. And Suboxone would be people that are a little bit better off, have a little bit better self-care, and don't need quite that short a leash, but something somewhat short, maybe once a week or once every 2 weeks, depending on how well they're doing. And then Vivitrol is injectable, and it works through the system, within anywhere from say 2 to 3 or 4 weeks. And according to this team, they would say that people had the best self-care and were able to maintain that self-care independently, were the best candidates for the Vivitrol because these people didn't require as much eyes on. I think that aside from the substance itself, and I'm talking about Suboxone here in particular, it and the leash that it provides an effect or a treatment benefit that is quite important for today's, especially the younger addicts that tend to do well for a while and then they drop out of treatment. And it's presumed when they're on Suboxone, they are usually much more apt to be leased into treatment and complying with treatment, and or there's more means to leverage them staying in treatment. There are those who would say, well, I've known plenty of people that were on Suboxone and they took it and they did okay for a while, then they drop off and they relapsed. And what I would say is that isn't the fault of the Suboxone. It's really the fault of the person and the person's team to hold them accountable, because we tell our clients that no single medication is going to constitute effective recovery and treatment. And Suboxone or methadone or Vivitrol, they're only going to be effective when they're coupled with a very thorough program and that the clients are held accountable to their self-care. And so we don't really refer to people being on Suboxone in that way. We call it Suboxone maintenance, and by that we imply something very different, which is compliance with treatment, regular visits to treatment, they're getting urine tested. We certainly hope that they're going to meetings and they're working their program in conventional ways, and basically they are tethered to or leashed to treatment, and they're kept in orbit and connected to treatment through the being on Suboxone maintenance and other means, and that is the most successful formula. So when people get down on Suboxone and methadone and they start to talk about how it's never worked, we would say that it's probably unfair to blame the substance itself, because the Suboxone itself never did anything other than what it's meant to do once it's inside someone's system. It's really the lack of follow-through and the lack of self-care. So we're really emphasizing not just which substance is best according to their ability to be okay out there in the world, but also that it is a part of a comprehensive recovery plan to which clients are held accountable. And certainly for very relapse-prone addicts, younger addicts especially that haven't matured enough in their lives to be accountable and responsible to the degree that's necessary to maintain their recovery, that this helps us keep them accountable to us and to their treatment. So this speaks to the importance of protocols and expectations and accountability. Yes, it is a lot of work to be working with clients that are on Suboxone. I'm just going to talk about Suboxone for a while now. They need rides to the prescriber. They need prescriptions to be filled. They need to learn how to take it properly. If it's sublingual, which is what most of it is prescribed in the form of these days, it has to be dissolved in a certain way. Otherwise, they're not going to get the full benefit of whatever doses they're taking. And then, of course, you have to work with them to keep them in treatment and accountable to all the things that you want to do. It's a lot of work. But I think it also makes us better too, because we have to work a little harder, they have to work a little harder, and there's just a lot more recovery going on. It can be a pain, but it's worth it in the outcomes. I do remember a time when I was working with some people that were very down on it because they just didn't have time for it. Oh, it's such a pain in the butt. Think of all the problems it causes. And, my response to that was, that's something that should not be a reason why we don't do it if it's helping people. If a client requires us to stay clean and it's helping them to grow and change, then so what if it makes us have to work a little harder on their behalf? So putting it all together, and this is a very general conversation, as you can tell, is that the challenge is not just understanding its action and understanding how to maybe tell about which substance is right for which person. It's also about how to put aside our own biases and to do so in a way that thinks about what's best for the client. I'll fully admit that I have a lot of problems with methadone because of the daily dosing and the fact that it's so very, very difficult to place people that are on methadone in the sober community. But that's my personal reaction. If it's helping someone to stay clean, then it's kind of our job to work with them to help them overcome that the best way they can, and to keep them clean and keep them alive. So, I'm not afraid of saying that, but I've seen many successes for people that are on methadone in spite of all the extra hurdles you have to go through to be on it, and some of the problems it causes trying to place people in the community. So, here at Recovering Champions, we're doing our best to identify those biases and to minimize the risk and to hold clients accountable, and I think we're doing a pretty good job of it. But it is an ongoing process, and we're getting better at it as we go along. And we're always willing to work with people that are on MAT, and we do promote it as an option for those for whom it makes the most sense. And we're always willing to do the extra work and go the extra mile to help people learn how to manage this better so they can later live more independently in the community. So that's our take on this subject, and that's all I have for today. So hope I didn't miss anything. Thank you.